Are they worsening? How long do they last? Has it been lasting for 3 days? Has it been lasting for, the past couple hours? Some patients will come into my urgent care clinic and it started 30 minutes ago. Intensity, this is very important with headaches. Is this something that's just came on and it's just, bothering them a little bit, or is this absolutely incapacitating? And we'll talk about, have you guys had lectures on bleeds and subarachnoid hemorrhage yet? Okay, so you know about the worst headache of your life. That is literally the question that I will ask every patient. Now, sometimes when you lead patients about that, they'll be like, oh yeah, oh yeah, oh yeah. So you want to kind of ask them like, is this like your other headaches? I was asking an ERP about it because I feel like every time you ask them, is it the worst headache of your life? They're like, oh yeah. And then I feel like in urgent care, I'm like, well now it's looking for a CT. So anyway, is it throbbing, steady, sharp, dull? Other symptoms that can come with headaches, migraines, severe headaches with bleeds would be, those are vomiting, upset stomach. Nausea and vomiting is very common with migraines. What kind of, are there visual symptoms? Anytime someone has a headache, you need to ask them, are you having visual changes with your headache? Ask every patient of mine that even talks about headache in clinic and they have a sore throat, how bad is your headache? Other neurological symptoms that you need to ask about would be, do you have trouble with speech? Do you have weakness in your face with this headache? Have you lost consciousness from your headaches? Okay, so obviously your patient comes in and they have facial numbness in a clinical setting, you're going to send them to the emergency department, okay? Where I work, when we sat in school, they taught us about Bell's palsy, and we talked about eyebrows to death, okay? But if a patient is having signs of stroke and you're in a clinic setting, how can you tell for sure that this patient isn't having a stroke? So it's kind of something that you're going to need to think about and look at warning signs where, does this patient need immediate imaging? We'll talk a little bit more about that. So we talked about mild, moderate, severe, disabling. These are the percentages of people, how much activity it limits and how you classify it. Headaches, differential diagnosis. So something else I was going to tell y'all. I had a lady that came in and she had a blood pressure of like 180 over 100 and said that she came in for a sinus infection. And I said, okay, well, where does it hurt? Right here. Okay, so is that, in your mind, a sinus infection? No. Your medical training tells you this patient's hypertensive and they are in denial, okay? So you need to think about, that patient said it was something else, but anytime someone has a headache, you got to think about all these things. And when you get out of school, you'll have them in your head. And even if you don't have all of these things in your head, you'll have the worst case scenario in your head. And that's what you'll think about with every patient that you have. But stroke and bleed is probably the top thing that you want to make sure that they're not having. So this is the International Headache Society classification of headache and facial pain. These are the types of headaches that there are. There's migraine, tension, cluster, headaches from trauma, metabolic headaches, which we'll go over. Some patients have facial pain, TMJ issues. Sometimes they have meningitis from an infection. Primary headaches are the idiopathic headaches, and then secondary, like any other secondary issue in medicine, is due to something else. This is a nice little diagram that I found from another PowerPoint that I stole. So if they have a headache, is it something that you can put a source on, something that you can find? Or is it something that's idiopathic, after a CAT scan, there's nothing there, then we work up, just treat it as is, but we'll kind of go through those. Organic headaches can be toxic, metabolic, infectious, vascular. Does the patient have an aneurysm? Is that why they're having a headache? Are they having meningitis? They have a tumor in their head? Those are, that's obviously something that's an organic cause. Toxic metabolic headaches, example would be carbon monoxide that causes a headache. These are the symptoms that they can have based on the percentage that's in the blood. Doesn't take a lot. Smokers have more, obviously. Toxic headache, again, drugs, lead, carbon monoxide again, formaldehyde, like, when you're in an anatomy lab and you feel like you're gonna just die. Because it smells so bad or your eyes are burning. Drugs that can cause headaches. Drugs are a big thing that can cause headaches. One of the biggest things is oral contraceptives that can cause headaches with patients. Women that are on hormone replacement therapy. Narcotics are a big thing that, your patients in the hospital get morphine and they'll be like, oh, the worst headache. Well, that's because you're really vasodilated and you're really enjoying yourself. So, metabolic headache. Again, these are some sources that can be from metabolic disease or sources. There's a list of that. Vitamin deficiencies can also cause headaches. Vitamin B12, thiamine, niacin, meningeal headaches or meningitis. So, you have a patient come in and, you guys, I graduated in 2014. I haven't been out that long. So, I rely on a lot of the other PAs that I work with to kind of, it's a year where you come out and, but you're learning every day. And, they come in with neck pain and then they say they have a headache. Oh, does this patient have meningitis? You need to make sure they don't have meningitis. Well, you got to put the whole puzzle together. That's when the PAs I work with are real seasoned. We'll be like, Lauren, do they have a fever? Do they have, is there something infectious going on? If not, make sure there's no nuchal rigidity. But I had a little, teenage girl that was like, oh, I can't move my neck. And I was just like, okay, well, Mom, if she's having that much difficulty moving her neck, that concerns me that she needs to go to the emergency department. I can't even do meningeal science because she would just literally light up if she moved her neck. And, that's concerning, obviously, but, does she have a fever? No. She probably has a muscle spasm. So you kind of have to put the whole puzzle together with this. And then brain abscesses, that will cause a headache, obviously. Those can be caused, these infections can be caused from viral illness, fungal illness, bacterial illness, and obviously HIV patients, cancer patients are more susceptible to that. Let's see. Moving on. Here's some fungal infections. Here's some parasitic infections. Extracranial masses. Do they have a carotid body tumor? Is it outside of their head that's causing their headache? Cholesteatoma. Fabulous headache. Here's an abscess. You guys seen the abscess pictures yet? Yeah. The ring. Notice how there's a midline shift there. That's very concerning anytime you look at a CT. All right, primary headaches. So there's no cause that we can find. This is a very good picture. I have not had a migraine before, and I've sat through the migraine lectures in PA school, and man, they're intense and they're long. But if I've not had migraines, my sister has, but that looks like if you're having a bad headache, what do you feel like? Most of them are women. Usually about 20s or 30s that they'll start having them. And family history is usually common. So as far as the mechanism of causing a migraine, they're still trying to figure out what exactly causes migraines. What are the neuropeptides and receptors that are going on? But what they figured out is that, there's usually some kind of trigger, which we'll go over, that will cause what they call cortical spreading depression over the brain. And that will cause the neuropeptides like serotonin, substance P, that kind of thing to kind of bind onto the vessels. This is the diagram of that. Don't worry about memorizing that. I got some of my information from my board's books. There's nothing like this in there, so you don't have to worry about all the neuropeptides, and I don't think your exam will probably be that in depth either, but when you look at the drugs, you know, something like Imitrex targets 5-HT, so that's something that is causing pain, so you want to know that that is a neuropeptide that's causing their pain. Migraine triggers, so stress, I think we should probably put that maybe at the top of the list. Drinking, skipping meals, weather changes. Some patients will come in and say, you know, I feel like the low pressure has made my headache start. And then women with menstruation will have them. And then you have to classify migraines. There's a lot of classifications, but you know, as far as basic understanding of migraines, you know, does it have an aura? Does it not have an aura? What is an aura? They thought to be related to intracranial and extracranial vasodilation, but that's not the case anymore based on research that they've seen. They don't really quite understand that either, how that works. It's kind of a work in progress. They used to think that it always preceded the headache, but it can also occur during the headache. And then it usually lasts less than 1 hour. The aura is not going to last for days and days and days. So that would be something you would ask, like, how long have you had visual changes? You know, about 30 minutes? Okay. But is that normal for you? So visual is number one. Most patients will have visual auras, where they'll have, I'll show you a scintillating scotoma kind of example, but you know, they'll see things, but they'll also, you can hear things. Now that's not to say that they're going to start having delusions. That's going to say that they're having like noises or ringing in their ears. That's a whole other story for hearing like voices. But they're having any kind of, you know, they can have burning pain, motor issues, and those are positive symptoms. When something's been added on that wasn't there before, and then you have negative symptoms where they actually lose something during the aura, like hearing or moving their body, which, again, if they can't move their arm, we need imaging, okay? Don't ever just assume, oh, it's just a migraine, the patient told me it was a migraine. I don't know about that. So, features of migraine, I highlighted pain because that's the duh. But then there's the photophobia. A lot of my patients, I will come into the room and they turn the lights off. That's when I know that they're, you know, that's when you know their pain is really bad. One of my patients yesterday had sunglasses on, and so, you know, obviously the light's bothering them. Nausea and vomiting is a sign, but, you know, make sure, do they always have some nausea and vomiting with their migraine? Have they had any kind of head injury? You want to make sure that they're not having some kind of bleed in their head, especially with older folks. Just always check the history like we talked about. This is my animated picture for the day. I think it's so cool you can copy and paste that in Sunday. I'm not into technology. Scintillating scotoma is the most common visual sign that you'll see with migraines. Blurred vision, I think, is what I hear the most, but obviously patients have, so yesterday I had a patient come in and he said, I have blurred vision in my eye. He had an extensive migraine history, but, and I'll show you when you get imaging, but he was like, this is worse than normal for me. And I'm having worsening blurred vision in my left eye. Well, I don't think that's something we can treat here in an outpatient clinical setting. I think if this is worse than you've ever had before, then you need to go get a CAT scan or let the ER doctor determine that you need a CAT scan, because I'm not going. And then there's all these symptoms that I kind of picked up, but these are all kind of like, you know, like we said, concerning symptoms. Obviously loss of consciousness, giddy. There is an ICD-10 code for giddiness. I still don't quite understand what giddiness is. I think that's just made me excited, but I don't know. Those kind of things. Some mood changes. Patients get really angry and they get agitated. I mean, most of us have had headaches. You're not in a good mood when you have a headache. But sometimes people can get depression from having headaches so much to where it affects their life. Again, this is what you consider in new headaches, like we talked about. Make sure that there's not a concern for TIA, stroke, hemorrhage, all that good stuff. So migraine, so this is how you classify, this is the criteria that are met for a migraine without aura. And there's a lot of wording in this. But the headache, lasts from 4 to 72 hours. How long did your headache last? An hour. Okay, probably wasn't a migraine. They usually last for several days. Or, usually like 48, 72 hours if they can't get it to cease with medication. And then they're usually unilateral. It's not usually like what we'll talk about, where it's just like their whole head squeezing feeling, and pulsations. Now, also with migraines, it's exacerbated. Then that would be something that maybe you want to think about for exams. Is it exacerbated by activity? Does movement make it worse? Do you have to go in a room, turn the lights off, and not move to make the pain go away? And then, is there nausea, vomiting, or both? And then, sensitivity to light and sound, like we talked about. And then with aura, they need to have one or more of the aura symptoms. And then, I'm sorry, I forgot that you guys are typing away, and I'm speeding through this. So, are we okay? Okay. And then, does McNeil still have you guys do a pee potty break if it goes? But I think we're going to get through this fairly quickly. What slide am I on?
37.
Okay. So, where was I? Okay, diagnosis. So with aura, you need to look at how long the aura lasts. Does it gradually spread? Is it unilateral with aura? I'll let you read that. It's just a lot of wording. But those are the criteria for migraine, with or without aura. So technically, when you talk to neurologists, migraine, imaging is not absolutely necessary, but you need to make sure that there's not other things which we'll go over that would make it necessary. Does the patient have an abnormal finding on neurological examination? Does the patient have ptosis? Well, that's not really something that we would consider with migraine. Do they have, their pupil changes? These are also things that you would need to get a CAT scan with patients that you're working up for migraine. Like we talked about, the first or worst headache they've ever had. Is the pattern changing? Is it worsening? I've had a young lady come in and say, I'm getting these headaches more and more, and they're becoming more severe. Well, who's to say that there's not some kind of tumor growing? It's not likely, but we need to make sure that that's not going on. Now, when they put headache was always on the same side, I feel like most migraine sufferers have it on the same side every time, so that one I wouldn't put to that. But new onset headache after age 50. Patients over age of 50 are at risk for other things like aneurysms, tumors. If they haven't ever had it before, that's not their second or third decade of life. So that's kind of an odd time to start having headaches. And then like we talked about, HIV or cancer patients are immunosuppressed. Do they have an abscess in their head that's kind of developing? And then symptoms of meningitis are also accompanied with it. Nuchal rigidity. Papilledema is also something that you don't want to just go, well, it's just a migraine. No, papilledema is not a symptom of migraine. And then so you can read the rest of the list. But, also, not responding to treatment. Has the patient tried everything that they normally try? Does the Imitrex and Toradol usually work for you? Yeah. Is this not working for you? No, and it's really severe and it's worse than I've ever had before. Probably needs some neuroimaging. So, dang it. You guys could cheat. I should just. So your patient comes in and you're in the ER. Worst headache of their life. What are you going to order? What kind of CT? Out contrast. So, yeah, they'll buzz you about that for your whole life. But that's, working in neuro, that's what you get. Patient falls, patient is on blood thinners, patient has trauma. Then you would get a CAT scan without contrast because you don't know if there's bleeding or not. MRI, if there's a tumor or a mass, that will look at a lot more soft tissue. So the CAT scan will look at bone and blood. MRI will look at soft tissue tumors and abscesses and masses. MRAs are looking at venous and arterial lesions like aneurysms. Usually there's a concern for aneurysm. Usually they'll do a CAT scan. The ER doctor's going to do a CAT scan. And then they can pick up an aneurysm on CAT scan, and then neuro will do further imaging such as MRI. All right. So your patient comes in, they have migraines, but they're mild, and they have no nausea and vomiting. What are you going to give them? You're going to give them something easy, something not as many side effects. Start from the bottom, just like you always would with any kind of treatment. Start trying with NSAIDs or Tylenol, and they may look at you like you're crazy, but try it. Or your patient may not have tried anything at all. And so, you want to ask them, have you taken anything for this? What have you taken? And then if they have nausea and vomiting, you add something like Zofran, Phenergan, those kind of antiemetics. And then if it's moderate, you would get something like a triptan, which we'll talk about. Those are your drugs like Imitrex, it's a generic sumatriptan. And that medication can be given sub-Q, so if you have a patient that has nausea and vomiting and they can't take anything orally, some patients come in and they want injectable Imitrex, and I don't have it at my urgent care facility. But they also have intranasal. And then topical Phenergan, rectal Phenergan. Then there's parental dihydroergotamine, which is a really long word. It's called DAG. So migraine treatment in the ER. If a patient goes to the ER, they obviously were not able to get any kind of relief from what they were doing at home. So when you're in the emergency department, or they just came in because they didn't try anything at home. So obviously you need to go through your history again. How bad is it? Check, a neurologic exam. Is there something that pops up? Is there something about the history that concerns you? Get a CAT scan if there's something that's concerning. Most ER doctors will get a CAT scan for any headache. These are the drugs that a lot of them will give. Reglan is a good one that will kind of help with nausea and pain from the headache as well. What I give in the urgent care setting that's very effective is Toradol. But remember that Toradol, I'll stick a Toralac down there. Remember that Toradol is an anti-inflammatory, so again, and they'll do this all the time. Have you taken anything for it? Yeah, 800 milligrams of ibuprofen. Oh, Toradol's out the door. So, you just took it, and then they'll come to the clinic. I'm like, I can't give it to you now. So, remember what your patient's given, make sure you're not causing interactions. Opioids. So, some patients don't even have migraines. Maybe they just come to the ER and they tell you they're having a severe headache. They could be opioid seeking. And these opioids are vasodilating, so it's going to just make their headache worse most of the time. But a lot of ER doctors will give things like Dilaudid, morphine, but some of them are kind of getting away from it. Sorry about my typos, I was typing that. but it's usually a last resort. Is it something you can give? Yeah. But try something that makes a little bit more sense pathophysiologically for the headache than just giving them narcotics. All right, rebound headaches. You've been taking so many ibuprofen that now you have a headache because you stopped taking ibuprofen. And it also can be from a withdrawal from caffeine. I mean, how many of y'all did not have your coffee when you come to class? You're like, I have the worst headache because my caffeine. So that's something, so it can be related to a drug. I mean, it's usually related to a drug. But it's usually lowest in ibuprofen and Toradol and those kind of drugs. But the highest risk is opioids. And then your immediate risk is Imitrex. So, you know, a lot of patients that have migraines that know that they suffer migraines have Imitrex at home. But I think if they take it all the time, then they can start developing rebound headaches. So in order to get that to stop, you have to take away the agent that's causing their headache for at least 3 to 12 months, which takes a long time. Something else that you can give a patient for headache would be naproxen sodium. It's actually prescription, it's not a leave over the counter. A lot of neurologists will prescribe that. Something else that they'll give in the hospital for migraine is magnesium because it's a smooth muscle relaxer. All right, there it is. We know these drugs, anti-inflammatory. Obviously, there's risk of cardiac. Ask the patient, is your patient 80 years old? You know, do they have kidney issues? Maybe you shouldn't give them the ibuprofen. Think about what Dr. Latasi is telling you. Don't give them the ibuprofen. But maybe give them something else. Like Imitrex is not going to work like ibuprofen on an old person. Maybe a better option for them. All right. Triptans. You doing good? Triptans are serotonin agonists. I apologize. I was talking about something else, but they also act on 5-HT. So they inhibit the release of those peptides, which obviously can make the headache better. It's best given at the first sign of a headache. And so if the patient just kind of carries on for a while, for like 24 hours or so, it doesn't work as well as when you give it immediately. These are some of the side effects that you would get if you gave someone a triptan. So if you're in the ER and the patient's talking about they have chest pressure, well, maybe we need to give them a triptan. But most common probably just be an injection site reaction. But also, you could give Toradol and Imitrex. That's okay to do. That's a really good combination. So DHE and ergotamine, they work on 5-HT as well. They've been proven to be effective for migraines. But DHE is proven to be effective more than just plain old ergotamine. Preventative medications. You'll see a lot of medications that are on tricyclic antidepressants, which are a lot of side effects, but sometimes that's all that works for them. So you'll come in, patient on their medication list will have something like amitriptyline, which can help with depression as well. Or propranolol is very popular for prophylaxis of migraine. And whenever, you wouldn't give this to everybody. You and I aren't going to, if we have migraines, all of us would be taking propranolol just to make sure we don't have a headache. This is whenever it impacts their daily life. They're having more migraines, more than 3 days a month. All right, and then anticonvulsants would be something like Topamax. You see a lot of patients on Topamax. Temporal arteritis is something you don't want to miss. It's inflammation of the cranial arteries. It's usually the temporal artery right here. When you do your physical exam, you push on that area, the patient can be tender there. And it's a headache that's severe, that's recurrent, persistent over weeks to months. It's usually in the older population. Other associated symptoms would be, visual loss and blindness, which would be, deceiving because then, well, maybe it's just a migraine, but you gotta just do your exam. But usually the tenderness over the temporal artery is a pretty good indicator, but If you're in the ER and you're doing a workup, then you can do an ESR and a CRP. Make sure they're not elevated. The treatment of choice is temporal artery biopsy. And then, so that kind of, those two things would be a board question, would be ESR and CRP are elevated, and then mononuclear cell infiltration and granulomatous changes would be something that you would see on boards. Treatment for that would be high-dose steroids and NSAIDs. Cluster headaches, they're unilateral, they're not a global headache all over, so it's kind of gets confusing with migraines, but it's brief, severe, constant. So if you'll notice the time period on that, that's a lot shorter than a migraine. That's minutes to hours, not hours to days. So the patients will also complain about burning sensation behind the eye. They also have unilateral tearing, which is another board question for cluster headaches. Horner syndrome, again, if your patient comes in with Horner syndrome, don't just let them walk out the door. They have pupil changes. They need a CAT scan, not just their head. Cluster headaches are usually exacerbated by alcohol or vasodilating drugs. They can be. But it kind of will, like, it'll wake them up at night, and then they'll just kind of keep having them for several days, and they're happening in clusters. We may go without them for a while, and it just kind of pops up, and they're having episodes. Again, thorough history and examination would be what you would use without any warning symptoms or abnormalities on exam. And then this is your boards. 100% oxygen is how you treat cluster headaches. I don't have a very good memory, so I can't tell you what questions were on my boards, but that one probably is on somebody's boards. And then Imitrex you can use, DHE you can use, tension headaches. So it's most common. Everybody talks about how they have tension headaches. It's 60% of your idiopathic headaches. There is no explanation, I mean, as far as the mechanism of what's going on in the brain for us to really discuss why it's happening. But they have the neck and scalp muscle contraction. And women, again, have so many things to deal with that make us have headaches. Detailed history and a physical is important. But it's necessary to rule out ominous signs again. So that's just like we talked about. I'm repeating myself just to make sure you guys don't miss anything scary. Tension headaches are the band-like headache. That would maybe be a catchphrase that you may see on boards. Global headache, not associated with any kind of preceding symptoms or aura, neurologic signs, or nausea and vomiting. Cluster and tension do not, they don't have nausea and vomiting with them. It's usually migraine. You could do an ESR, just to make sure that's not temporal arteritis. You know, if you're worried about, again, you go through your exam and there's something that's not right, you can do CT or MRI. All right. So these are mild, and this is something that somebody is not going to die from, so give them some Tylenol or some ibuprofen. Ask them if they've taken any Tylenol or ibuprofen. And then they can get rebounds because they keep taking it. And you need to emphasize with patients how much ibuprofen they can take every day. I had a patient tell me, well, I took 6 pills at one time. Why did you do that? Because it's over the counter. Okay, that doesn't mean that you can do that. You're going to be pooping blood next Monday. I mean, you can't do that. So, anyway, so that can happen a lot because they take so many drugs, but also respond to other meds if they fail conservative therapy. And then, consider, they have a lot of the same triggers, so consider counseling, physical therapy for the neck if they're having like some neck spasms, which could be causing it. some relaxation techniques. Diseases of the peripheral nerves. Biggest thing we'll talk about will be diabetic neuropathy. Polyneuropathy, these are your definitions. It's generalized over more parts of the body than something like just the feet. And then peripheral neuropathy is more of an example of diabetic neuropathy. Mononeuropathy is a single nerve that you have that's possibly entrapped, like carpal tunnel. So again, polyneuropathy is more global. It can occur secondary to toxins, vitamin deficiencies. You know, B12 is not just your feet. B12 is the lower extremity, so it's a little bit more global. Complications from kidney failure is a possibility, or cancer. Diabetic neuropathy, that may be the first symptom that you have from the patient that they have diabetes. Anytime a patient tells you, well, I have neuropathy, and a patient tells me, I have neuropathy. Is it diabetic neuropathy? No. Have you been worked up for diabetic neuropathy? Yes. All right, well, I don't know why you have it, but I'm not going to figure that out in urgent care, but it's usually, you need to rule that out anytime someone has numbness or tingling in their feet or their legs. So most of the time, it's mixed by a sensory, motor, or autonomic neuropathy, where they can have kind of issues with motor function and feeling, but then the remaining are just usually sensory loss. And it can be really painful for them. They can have the numbness and tingling is going to be like your catchphrase anytime you ask a patient. The numbness, paresthesia, you never say, do you have any paresthesias? No, you ask them if they have numbness or tingling. Paresthesias would be the tingling sensation. Burning, pain. They're going to have it more often than their legs. They don't, you know, if it's really bad diabetic neuropathy that they've had for years and years, and they have poor glucose control, but it could be in their hands at that point. I think it worsens, you know, it usually starts in the legs, but if it gets to the arms, you know it's kind of been going on for a long time. And it's also, you know, diminished reflexes. That's your somatosensory kind of motor issue that you're having. It affects the nerve endings. So you may notice that. So have you done your physical exam course yet? Yeah. So you know, like sharp, dull, all that pinprick, so proprioception. Now, I'm not a primary care doctor, but I think that would be something to do more in the primary care setting to rule it out. So monofilament, did you guys get your free like monofilament things yet? They have a little, it's just like a little piece of plastic that's at the tip, and it's just got so much pressure on it that when you push it on, you guys know what I'm talking about? Yes. So yeah, that would be some, I don't know, I don't know how long you guys have been doing this, so I'm just trying to make sure that I don't talk over everybody's heads, but you guys are good. Great. So nerve conduction those studies can help determine if there's actual neuropathy there. But you also need to rule out B12, you know. First thing you order a patient that comes in with numbness and tingling in their legs is going to be an A1C and probably a B12, and then check for other issues like hypothyroidism. Zebra would be paraneoplastic amyloidosis. You hit the lottery if you got that one. They wouldn't hit the lottery. But optimal control would be diabetes control. You need to make sure that their blood sugars are improving, that they're not out of control, patient's compliant. How often do you take your blood sugar? Oh, every now and then. Well, you need to take it more often, and maybe you keep a log, try to get some better control of your diabetes. Tricyclics, gabapentin has, you know, had mediocre kind of, they're saying now that it's almost like a placebo to give to patients, but I know a lot of neurologists and they use it still, PCPs use it still. Some of the newer drugs like Cymbalta, Lyrica, they work a little bit better for patients in studies that I've looked at. But again, you have a patient on boards that has diabetic neuropathy, first thing you're going to do is control their sugars. And then foot care, have the patient look at their feet. If you can't feel, like in that picture, yourself step on a thumbtack, and then you have diabetes, which causes poor wound healing, you're going to be up a creek. So you have to explain to them, you've got to look at your feet every single day, the bottom of your feet. And if you see a wound, you have to come in because, they're obviously, it's almost like a double-edged sword. I mean, you can't feel it, and then you're prone to getting worsening infections. Guillain-Barré, a lot of times due to viral infections like Campylobacter, CMV, mono. Its keyword with this is, it's a subacute polyradicular neuropathy. It's usually immune-mediated because it's after some kind of illness, and sometimes the patients don't even know they have the illness. Sometimes it can be really due to vaccines. I think a lot of people associate Guillain-Barré with vaccines, but it's usually due to some kind of viral illness that the patient wasn't aware that they had. So initially, we know that it's ascending. It's not going to start at the top, it's going to start at the bottom and work its way up. So initially the patient just may have some trouble walking. Ask them, have you recently been ill? I mean, obviously, patient comes in and they had mono and they're having trouble walking. It needs to be deep back in the files of your minds, but it's always a possibility. I think sometimes it takes a little longer for patients. They have pin and needle sensation in their feet. Do you have diabetes? That's also going to be something in your differential. So these are all the things in your differential that you have to keep in mind. And then they have weakness in their legs, but they have deep tendon reflex loss early on. So you do the patellar reflexes, and I'll tell you, I do patellar reflexes a lot, and a lot of times you just can't get that leg to pop up. When you guys have done your physical exam course, it's frustrating. So just because a patient doesn't have their leg kicking you at that point doesn't mean they have Guillain-Barré, but with all the other symptoms, that's something to consider. His history and physical, there really isn't necessarily now you can do a lumbar puncture, get CSF, look at elevated total protein and cell count, which will be normal, but the total protein will be elevated. But if you have a patient who was walking last week and is not walking today, it's usually Guillain-Barré that you would put in your mind to think that that could be happening. And then they're progressively getting worse. Did they stop walking, they had no injury, and now it's moving up and they're having a hard time moving their arms. That's when you get concerned. And electromyogram can also be something that you use for diagnostic criteria. But again, Guillain-Barré, are you concerned about, the biggest concern is respiratory failure. That's board's question as well. And then things that they would treat with plasmapheresis, IgG, immunoglobulin. So I haven't seen a lot of this, but complex renal pain syndrome goes on your objective, so we will talk about it. But it's usually the distal limbs, it's usually related to some kind of fracture, trauma. The patient will have pain, swelling, limited range of motion. Vasomolar instability, they can have cool or hot skin. Sometimes osteoporosis in that limb. It's characterized by an array of painful conditions. It's basically another one of the things we're talking about, history. Patient had trauma, patient had a fracture, they're kind of having all these problems in the limb itself. It's not dermatomal, to where it would just be like T6 dermatoma or T5, or T6 and T5, I'm sorry, C5 and C6, where it would be your arms, or L4, L5, like your legs, but it would be like a certain area that the patient's having a problem with. It's more common in women. Usually the age of life is most menopausal women. Type 1 is the most common. It's usually with a peripheral nerve injury. so type 1 is without peripheral nerve injury, and it's the most common. Type 2 is with peripheral injury, but without peripheral injury is the most common that you'll see. Which I can tell you that there's probably just almost idiopathic, but when they're saying that the cause of it is fracture, injury, that kind of thing, well, then that's a peripheral nerve injury. So maybe they didn't have injury. I'm not sure. I know that that's a little bit confusing. I'm sorry about that. Yeah, persistent pain. They don't know why it happens, but usually you're going to have to do some kind of treatment for the patient. Again, crush injuries, surgeries. No precipitating factors were identified in 10% of the patients. So, like we talked about, they're going to have autonomic symptoms, sensory changes in pain. They can have some trophic changes in the limb as well. Again, the pain is continual, but it can kind of come and go. Burning, stinging, very neurological type of pain, not necessarily like fracture kind of pain. It's a nerve-ending kind of pain. And it is exacerbated by movement, temperature, contact, stress. So these are some sensory symptoms that they'll have, but I also put the definitions down for you. Hyperalgesia is an abnormally heightened sensitivity to pain. And then hypoesthesia, which I'd love to know about, is diminished capacity. You can't feel anything. They'll have no, they won't be able to feel anything in their arm. But then there's then they can also have pain from repetitive stimulation in that area. All right, so motor, they can have problems with movement of the limb, pain, contractures. Those would be kind of the trophic changes that you would have. And then again, they have some skin temperature changes, sweating, coolness, edema. And then the trophic changes, again, would be like they have some hair, increased hair growth in that area, contractures, decreased nail growth, skin atrophy. So there's no way to diagnose this. You just have to look again at your history. That's what most of this PowerPoint is about, is history. No gold standard. Again, diagnosis is done by circumstances of what happened in your history. Was there nerve root injury? Is it just a limb? Was there some kind of trauma? And then, again, these are the diagnostic criteria, which we've talked about already. Patient has to have 1 in 3 of these symptoms of the 4 categories. All right. I went over Glasgow Coma Scale because we're going to cover concussion. Have you guys looked at the Glasgow Coma Scale? No? Okay. So what you need to know is that 3 is as low as it goes. You never say that the patient is a Glasgow Coma score of 0 if they're dead. Whoever made this up decided that 3 was going to be the end number. So patients that come in with traumas that are intubated, head injury, you know, they would have no eye opening to pain, no verbal response because they're intubated. They're pretty much, they don't want to say this about a patient, but that's the closest to dead that you're going to be. And then you and I are GCS of 15. So anytime someone comes in, you want to chart their GCS if they've had a head injury, a traumatic head injury, okay? They've been in a car accident. You need to make sure, if they're talking to you, sitting up, chatting, they're 15, okay? They follow your commands. You don't have to go through this whole rigmarole. You need to read it, kind of keep in mind what a 15 is, but you don't have to do this every single time. I did a little bit of work with neurosurgery, and so traumas will come in, and there's been a really bad head injury, and you know, you go in there, you immediately say the patient's name, Mr. So-and-so, can you hear me? No response. And then we have to go on to work toward more painful stimuli, which is kind of hard sometimes. there's usually, would have to do some kind of axillary like pinching, and that hurts. So when a patient, or sternal rub, but we didn't really do sternal rub, it was more of an axillary pinching, that hurts, and if a patient's not responding to that, they're not doing very well. And even then, if you're intubated and you're unconscious, your nervous system is to grab at that person that's pinching you, even when you're not awake. And then eye opening to verbal commands, so they open their eyes again, and then the verbal response, do they talk to you? Do they mumble? Are they confused? Are they oriented? Motor response, so withdrawal from pain. Do they move their arm? Do they grab at your arm when you're doing your exam? And an inflection to pain would be like the red nucleus. And you guys take neuroanatomy. Yeah, so it's worse when they have the extension to pain versus flexion to pain, which means that the injury is not as good. So again, you had a head trauma with concussion or possible head bleed. When do you need neuroimaging? So again, we already went over this PowerPoint, so put it in there again for you. And then concussion, so you'll have a lot of patients that will come in to the ER that will say that they've been in a car accident or kids that have hit their head. It's usually an acceleration, deceleration force, the coup, contra coup, and it will cause contusions of the brain, but it is only a mild contusion, whereas the more severe things cause actual bleeding on CAT scan. Hallmark symptoms of a concussion. Obviously, they're going to have a headache, but when you add the headache to confusion and amnesia, do they remember the event before it happened? Do they remember what happened after? Did they pass out? How long did they pass out? It's very important to get all of that information together so you can determine, do I need imaging? Did the patient lose consciousness? How long did they lose it? So these symptoms pop up with concussion early on. Again, if your patient has nausea and vomiting after they've hit their head, they need a CAT scan, okay? But any of these kind of symptoms, man, I'm really sorry for the typos, guys. I really am. I used to just watch them in class and go, man, I did not look at that. Again, and then things that you would notice later on after the injury, days after, would be sensitivity to light, a little bit of agitation, not sleeping. And other signs of concussion, inability to focus, slurred speech, which again, not something to make sure that everything's okay. Inability to focus, incoordination. What part of the brain would you worry about if the patient wasn't coordinated? You got to make sure that there's not a posterior bleed back there. If the patient can't walk or having trouble moving arms and legs. Memory deficits are the hallmark of concussion. And then test of choice would be, again, your head CT to make sure that there's no bleed. So there's limited axonal injury with the concussion. But when you do a CT scan, if it's a concussion, you won't see any bleeding on there, okay? It's bruising that's so minor that you don't see it on a CAT scan. But then whenever you, if you do see bleeding, then you wouldn't classify it as a mild TBI. Then you're starting to look at things like subdural, subarachnoid hemorrhage. All right, so, you guys doing okay? Okay. No pee potty? You good? Okay. So, again, with concussion itself, not headache, when do you need a CAT scan? Again, your GCS is less than 15. It says 2 hours after injury with technical standards on up to date. If their GCS is less than 15 and they hit their head, CAT scan. And then I thought this was really good. Suspected open or depressed skull fracture. That's something that you probably don't need to get your PAC for to know. But then there's also the signs of the basilar skull fracture. I'm gonna tell you guys a cool story of these really quick, okay? I went to Buffalo, Oklahoma for my primary care rotation, which was like the furthest out of any of my classmates. I drew like the short stick. And it was like 3 hours up. It's north of Woodward, because most of us don't even know where Buffalo is that correct? Okay, everybody's like New York. And so my 4th day of rotations, I was staying in the hospital, and a motor vehicle accident came in, and like up there, like they don't have like uniforms like IMSA. They wear like those wolf t-shirts, and I'm like, are you guys the paramedics? And they're like, yeah. And it's like this very elderly man who was hit by a semi, and I was the only provider there. Like my PA, my preceptor had to come up to the hospital. And so he has on a backboard and he's got a collar on, and I'm like, and the nurses, I don't mean to say this, but like, they don't care that you're a student. And they're like, so what do you want? And I'm like, this is a full-on trauma, and they want me to order everything. And I'm like, vital signs, EKG, start an IV. I mean, it comes to you, when you have to be in that position, you're like, well, I guess I better figure this out. And the little LPN student, I told her to get vital signs. She starts walking out the door. And I was like, oh, no. We're in this together. So, his name was, I won't tell you his name, but he was like, I want to get off this backboard. And I was like, no. He was like, I want to take off this collar. No. You guys are the person that protects the patient, so don't ever let them tell you what to do, because I'll tell you what happened. So then he's bleeding, he has a arterial bleed in his scalp, and I'm like, that's a lot of blood. And I'm like holding pressure to it, and so the PA comes in and he goes, oh, Lauren, don't you know all bleeding stops eventually? And I'm like, oh, yeah. Just hoping it doesn't happen right now. But, so then he starts tying off this arterial bleed, which was really cool. He actually was tying the vessel in the scalp itself. And he's like, have you done sutures before? And I'm like, I'm paid. It's my 4th day, so let's do it. So then we start talking, and all of a sudden, this patient who was talking, wanted to go home, is just, and I'm like, so, he's snoring, but he's apneic, and he passed out. And I'm like, wake up! Wake up! And he's sewing over there, and the head's just going like this. I'm like, wake up! You can see the ecchymosis under his eye starting to develop, and his pupil getting bigger. And as they will teach you, which I don't know if they've done this yet at OCU, but everything that you need when you're in the boonies, the CAT scan's down. So what do? And so we called Metaflight, and I'm pretty sure he had a hip fracture too, but who cares? That was, we just focused on his head so much, but then he woke back up again. And I was like, are we serious about this now? You need to call your daughter, and we need to get you to the hospital. So I watched the helicopter fly off and take him to Oklahoma City. And that is like the coolest story. And you know, when I came back, I was telling my classmates, guess what I did? In Buffalo. So, signs of basilar skull fracture, and that's when you would need it. Obviously, he did not just have a concussion. So anyway, good story. So the patient needs to be monitored for 24 hours. You know, if there's a CAT scan done or there's not, patient's relatively stable. You've heard of people waking them up. You can try, you probably need to be waking up a couple of times. I haven't worked in the emergency room. I don't know exactly what they're telling them. But they need to be monitored for 24 hours. But if they're not waking up when a family member goes to wake them up, that's obviously a problem. Or a seizure, or confusion. They need to be brought back to the hospital for all of these things immediately for CAT scan or admission to the hospital. Post-concussion syndrome, we are almost done. So it can happen after a concussion, obviously. But this happens a lot with that you have to worry about with MMA fighters, boxers. I don't know if any of y'all know who Dr.